Record. Okay. We can just start off like we did last time. So,
Hello, I'm Hector.
Mia. Mia, can you hear us?
Are you mudded, Mia?
Can you guys hear me
There we
now?
go.
Yeah, we can hear
Yeah.
you now.
Okay.
Okay, I'm so sorry.
No, you're good.
Can we just all
Hector?
talk to make sure we all can hear each other?
Yeah, can
Yeah.
everyone hear everyone?
Yeah, I think so.
Okay,
Yeah.
cool. All right. Oh, okay. We'll get started again. All right. Hello, I'm Hector,
I'm Mia.
I'm Madison.
I'm Kaylee.
I'm Julia.
And I'm Ella.
and this is our Group B5 Exercise 318 presentation.
So for our scenario, um, his name is James Patterson. He's 21 and he's a full-time college student studying engineering. And he's former high school basketball player, and he currently plays recreationally once a week. Participates in weightlifting at the campus gym 3 to 4 times a week, but he often skips stretching and mobility work, and regularly carries a heavy backpack, 15 to 20 pounds daily for long periods. Lifestyle factors: he spends 6 to 8 hours daily on a laptop for coursework, and he has a limited sleep schedule with 5 to 6 hours on average. Drinks coffee 2 to 3 times daily, and a moderate stress level due to balancing academics and extracurricular activities. He reports no major medical conditions or injuries, but he frequently experiences tightness and occasional pain in the upper trapezius region, particularly on the right side, and complains of tension headaches 1 to 2 times per week, often after long study sessions or gym workouts. So the posture assessment reveals forward head posture and rounded shoulders, and James' physician has ruled out any structural issues and recommended corrective exercise to manage muscular imbalances and prevent further discomfort. And then the health risk assessment form attached. So he has not had a heart condition that should only perform physical activity recommended by a doctor. Does not feel chest pain when doing physical activity. Has not lost balance because of dizziness or lost consciousness. Does not have a bone or joint problem, and is not on any blood pressure medication. But he does experience tightness or discomfort in the upper back, shoulders, and neck during or after physical activity. Feels muscle imbalances such as one side of the body being tighter, and he does carry a heavy backpack and engage in activity that contributes to muscle strain. And his healthcare professional has recommended that he address postural imbalances and muscular tightness in the upper extremity. And he spends a lot of prolonged periods sitting or studying in one position, and feels a lot of stress in his muscles. And he does not perform more or cool down exercises when playing basketball or weightlifting. And he does often skip mobility or stretching exercise in your current workout routine. So, because he had answered yes to these musculoskeletal health questions and he is cleared for activity, we would move forward with an exercise plan for treating these muscular imbalances.
So here we're going to be talking about the static posture analysis. In the anterior view of the posture analysis, the knees appear closer together, suggesting some knee valgus, which may be caused by tight adductors. The left shoulder is also elevated, likely due to tight upper traps and levator scapula. Weaknesses in the glute med, minimus, and vastus medialis may be contributing to the knee instability. Additionally, weak lower trapezius and rhomboids might be causing the uneven shoulder alignment. In the lateral view, there is a slight anterior pelvic tilt, which could be caused by tight hip flexors, particularly the iliopsoas. The knees look slightly hyperextended, possibly due to tight gastrocnemius and hamstrings. Rounded shoulders suggest tight pectoral majors and minors muscles. Weak glutes and hamstrings may be failing to counteract the pelvic tilt, while weak rhomboids and lower traps could be leading to the rounded shoulders. The head is slightly forward, which may indicate weakness of the deep cervical neck flexors. For the posterior view, the knees show slight internal rotation, contributing to knee valgus, likely caused by tight adductors. The scapula appears protracted, indicating tight pectoralis minor and serratus anterior muscles. Weak glutes and may be contributing to knee instability, and weak rhomboids and lower traps may cause scapular protraction.
So when performing the overhead squat assessment, the normal findings are usually the anterior, the knees, and the feet are parallel to each other. When looking at the lateral view, the back stays neutral and parallel to the legs, and the arms stay upward and don't fall forward. When looking at the posterior view, the heels are supposed to stay on the ground, and there's not a asymmetrical shift to either side. So in the video for the anterior view, it's shown that there was knee valgus. Some potentially overactive muscles could be the adductor complex that causes the legs to adduct, turning the knees inward. The biceps femoris, it could cause excessive external rotation of the fibula, causing the knee to go inward. And then the lateral gastroc, which limits ankle dorsiflexion, causing the tibia to internally rotate. And then some potentially underactive muscles for knee valgus is the medial hamstring complex. It's not able to keep the knee from internally rotating. There's also the medial gastroc, and it can't control the rotation at the tibia. And then the glute median max, which causes the pelvic tilt. When looking at the lateral view, you can see the low back rounds. Some potentially overactive muscles could be the hamstrings, causing a posterior pelvic tilt. The rectus abdominis, which causes a pelvic tilt. External obliques also causing a curve in the spine because of the posterior pelvic tilt. The potentially underactive muscles can be the glute max, and it's relying more on the lumbar spine or for hip extension, causing it to round. And then the erector spinae, it's not keeping the spine straight. It's not stabilizing the spine like it should be. And then the hip flexor complex, the hips cannot flex like they're supposed to, causing the lower back to compensate. And then the latissimus dorsi is not able to stabilize the pelvis. Another view compensation you can see from posterior is that the feet turn outward, and that can be because of a overactive soleus and an underactive anterior tibialis, and that can just cause the feet to externally rotate outward.
Okay, for the single leg squat, it's a traditional assessment that assesses the dynamic flexibility, core strength, and balance. The client will squat down on one leg to a comfortable level and back up, evaluating the single leg squat from an anterior view only. And then the specific kinetic checkpoints include the analysis of the knee and the lumbopelvic hip complex. The patient showed the same compensations on the left and right side, and both knees moved inward, adducted, and internally rotated. And then some overactive muscles include the biceps femoris, the short head, which internally rotates the knee, and the adductor complex. If overactive, it leads to knee valgus, and also the lateral gastrocnemius and the vastus lateralis. And then some underactive muscles include the medial hamstrings and the medial gastrocnemius, which internally rotates the tibia. Also the glutes, which will lead to a knee valgus when they're weak. The patient also showed the torso in rotation when going down for the squat on both the right and left sides. Some overactive muscles include the internal obliques of the same side of the stance leg and external obliques of the opposite side of the stance leg, and this affects the core stability. And then some underactive muscles, which would be opposite of the overactive, and also include the glutes on the same side of the stance leg, which affect the stability as well.
Okay, so now we're going to move on to gait analysis. So in a gait observation, the therapist is observing and analyzing a patient while they're walking. So there are 3 views that are individually analyzed: anterior, posterior, and lateral. The specific kinetic chain checkpoints in the gait assessment include the observation and analysis of the feet and knees in the anterior view, the LPHC and feet in the lateral view, and the feet and LPHC in the posterior view. And then all three views will take into consideration the head and shoulders. So normally the feet will be straight, the knees will be in line with the toes, the low back will maintain a natural lordotic curve, and the shoulders and head will remain in a normal alignment throughout the movement. And in the gait assessment, this patient has externally rotated feet, rounded shoulders, and a forward head position. So some of the potentially overactive muscles in the feet being externally rotated could include soleus, the lateral gastroc, the short head of the biceps femoris, and the TFL. And then some potentially underactive muscles could be the medial gastroc and the hamstring, the gluteus medius and maximus, and the sartorius. And then for a lateral view compensation of the head migrating forward and the shoulders being rounded, some potentially overactive muscles could be the pectorals for rounded shoulders and the lats also for rounded shoulders. And then the upper trap and the levator scapulae for the forward head. And then some potentially underactive muscles could be the middle and lower trap for rounded shoulders, the rotator cuff muscles for rounded shoulders, and the deep cervical flexors for forward head. And some of the muscles, specifically why they're being overactive or underactive, for feet external rotation, the soleus could be overactive to help stabilize the ankle due to compensation for weak medial muscles. The lateral gastroc could become overactive as it assists with external tibial rotation and ankle stability. The short head of the biceps femoris could be overcompensating by externally rotating the tibia when the feet are rotated outward. The TFL activates to stabilize the hip when alignment is altered by foot external rotation. The medial gastroc medius and hamstring weakness here leads to instability and reduced control over tibial alignment and foot position. The gluteus medius and maximus underactivity affects hip stabilization and control to femur rotation, controlling the compensatory patterns. And then in the sartorius, underactivity limits the internal rotation and stability of the hip during knee motion. And then for the forward head and rounded shoulders, the pectorals are overactive and pull the shoulders forward into a rounded position. The lats have overactivity that contributes to internal rotation and downward pull of the shoulders. The traps will contribute to a forward head and they become overactive due to support the head in its forward position. The levator scapulae contributes to forward head and overcompensates to elevate and stabilize the head and neck. And the middle and lower trapezius, which leads to rounded shoulders. Weakness here reduces the ability to retract and stabilize the scapulae, worsening rounded shoulders. In weakness of the rotator cuff muscles, underactivity limits external rotation and stabilization of the shoulder joint. And then in deep cervical flexors, weakness causes a lack of support for proper neck alignment, contributing to forward head posture.
For the added test, the client performed the Davies exam. The video shows the exam being performed. Taking a look at the video, we can notice quite a few things starting off. For example, the client shows clear signs of fatigue. He got tired relatively quickly, and you can notice on his left side of his body, he has a higher shoulder. This is both due to overactive and underactive muscles. To begin, the upper trapezius muscle is overactive, which can be the reason for his elevated shoulder during the exam. We can also notice some rounding of the shoulders with difficulty to maintain stability. This can be a result of overactive pectoralis major and minor muscles. There's also a lack of symmetry when performing the exam, pointing to possible tight levator scapulae muscles. It seems the patient has underactive muscles as well that lead to right-sided dominance. For example, the lower trapezius is underactive, which forces him to compensate, and it presents with difficulty in stability. The same can be said for the rotator cuff muscles and the serratus anterior, as there is visible winging with reduced stabilization, leading to less controlled movements, all to show compensations that result in elevated shoulders, decreased range of motion, control regarding the scapula, and lastly, elevated shoulders.
There's our essay.
All right, good job, guys.
Cool.
Let's see here. Stop sharing, recording. I think that's everything, honestly.